All right, good afternoon, everyone. Thank you so much for joining us on this lovely Wednesday afternoon. I know it's sunny outside. It may not be warm, but it is lovely. So I appreciate your time with us during the lunch hour, instead of sunning yourself somewhere. So just to get us started, before Dr. Packham jumps into his presentation, I'm just going to open up with some housekeeping. So first and foremost, this webinar is being recorded. I'm going to try to make the recordings available as soon as I can. I'm having some technical glitches with that. I'm not an IT person, so I'm just figuring this out as we go. But we should also, you may also have access to this on some of our partner websites. We'll get to our partners in a second. Please keep your microphone on mute unless called upon. I do reserve the right to go ahead and mute you if you forget to put yourself on mute after speaking or however that may come to play. Please enter your name, title, and agency in the chat if you haven't already. And we're going to hold time for questions at the end of the presentation. And when you do have a question, please use the raise hand function to ask your question. I will also keep an eye on the Q&A function to see if anyone's using that as well. So thank you so much. This webinar is part of the pre-legislative behavioral health webinar series, and this is a collaborative project between all 5 of the regional behavioral health policy boards, the Nevada Public Health Nevada Public Health Association's Advocacy and Policy Committee, and also the Behavioral Health Association of Nevada. The purpose of this webinar series is really to help you, the participants, prepare for the upcoming legislative session. So we want to make sure that you have the most up-to-date information before the legislative session starts moving, so that if there's anything that you need to keep in mind, if there's anything you're watching, you have a little bit more context as to what this might mean. We have made the best efforts we can to include speakers who are subject matter experts in this series, who are also able to give this information without any sort of political or financial gain. Upcoming webinars. So next Monday, the 27th at noon, we have Elise Monroy will be giving an Advocacy 101. And that is to help people understand how to engage in the legislative process, even if you work for a public or nonprofit agency. So I know that some of us have difficulty navigating these lines, particularly if you receive federal funding and aren't allowed to lobby. How can you participate without overstepping any boundaries? Tentatively, I have this almost hammered out. Next Thursday at noon, we're going to have a panel with a couple of past legislators on how to engage with them. What is that experience like? How do legislators want to be engaged with? And if there's any etiquette to be mindful of. And the last one we have currently scheduled is next Friday, the January 31st at noon. This will also be from Elise Monroy on reading, understanding, and using state budgets for advocacy. I know there's a lot going on regarding state budgets right now. A lot of questions coming up. And so she's been doing a lot of research to make sure that the information that she's able to provide is timely and useful and has utility. Other webinars that we're currently working on scheduling in specific details. We're going to do some about the crisis response systems. The state is doing a ton of work to flesh this out and making plans. So we want to be able to get you that information in a timely way about what their current efforts are, what their timelines are looking like, and where that money might flow. We also want to do at least one, it's looking to maybe 2 or 4, somewhere in there, webinar sessions about youth behavioral health. We also are going to have more about behavioral health workforce development, and we're also going to be doing a panel with representatives from the policy boards as well as their RBHCs on the different bills that the policy boards have out, and also what kind of our experiences and perspectives are as far as what our communities may or may not need. A little bit about the regional behavioral health policy boards. There's currently 5 regions. SB 78, amongst all their revisions, will change that to 3. The boards currently consist of 7 to 13 members, and these seats are really to represent both local and professional perspectives. So we always want to give preference to folks and professionals who are within the region that we serve and represent. Sometimes we're not able to get that. For example, Dr. Erica Rist is based out of UNR School of Med, and she happens to be the psychiatrist, rather, excuse me, on the board I serve. But really within that, they advise state level agencies and commissions and are allowed one BDR each legislative session. These board positions are completely volunteer, so there is no benefit or monetary benefit to participating. Just a quick rundown of the different regions. We have Washoe, which is just Washoe County, the northern region, which is the western rural counties, the rural region, the region I serve, which is all of those northeastern counties. There's actually 6 in there. The southern region in green, that's those south and south central rural counties. And then Clark, which includes not only Clark County, but also the southern tip of Nye County. So that includes Pahrump. Each of the regional behavioral health policy boards is assigned a coordinator. And so these are the regional behavioral health coordinators. Our job is to align our work with the needs of our communities that we serve, as well as our board priorities. And then if there's any funding requirements, because we are funded by DPBH, then making sure that we can weave those deliverables in a meaningful way. We're also the unofficial staff of the policy boards themselves. So we do all the administrative tasks associated with their functions. We work to advocate for our communities served to state agencies as well as other representatives. And we connect local organizations with resources and opportunities that may be available at the state or federal level that we're aware of that would be meaningful to them. We also attempt to organize our stakeholders as much as we can. And like I said, we are funded through the DPBH Bureau of Behavioral Health, Wellness, and Prevention, through the CDC's Overdose Data to Action Grant, as well as the Mental Health Block Grant. However, we are not state employees. We are each seated in a local level organization, which enables us to really advocate to the state on behalf of the communities that we serve. So here's your 4 current regional behavioral health coordinators. The Clark RBHC position is currently vacant, but we have Dorothy Edwards up in Washoe. For the northern region, which is again those western rural counties, there's Sherilyn Rar Woods. Mark Funkhauser is the RBHC for those southern and frontier and rural counties. And then I am the RBHC for the quote unquote rural region, which is the north and northeastern rural and frontier counties. Again, this is a collaborative project. And with that, I am going to go ahead and pass the baton to Dr. Packham.
Hi there, Valerie. Thank you for the opportunity to present to this group today. I think I'm going to begin my discussion by just pointing out that I've got the cold that half the planet seems to have right now, and if I stop, it is to get a little sip of hot tea. Okay. The other thing, Valerie, I think we're small enough. If people have questions, I would be happy to entertain them, but I will maybe have you ask folks to drop a question or comment in the chat or speak up. Does that work for you, Valerie?
Works for me. So yeah, if you have any questions or comments, there should be a Q&A option down at the bottom of your screen. And so if you want to pop your question in there, when I see it, I can go ahead and wait for a time when John is ready to take questions and go from there.
Excellent. All right. Again, my name is John Packham. I'm co-director of the Nevada Health Workforce Research Center. It's a unit of the Office of Statewide Initiatives up here in Northern Nevada at UNR Med. I want to give a plug at the beginning and end of my presentation about some resources that I think you all will find useful as you approach the upcoming legislative session. Hot off the press is an update to our Rural and Frontier Health Data Book. This is the 12th iteration of that. We deliberately aim to have that out and available to lawmakers and the public and advocates and health professionals such as yourself who are on the call today for just hopefully to make you a little bit smarter about all things health. But there's a lot of information at the county level in this particular report, and encourage you to check that out. I think Valerie's going to drop a PDF of that in the chat. I will have hard copies available in 3 or 4 weeks and work with Valerie and the other regional coordinators to get that out to you as well. Another resource that I want to make you aware of is the Nevada Instant Atlas. That is basically an archive of everything and then some that has appeared in the data book over the last 25 years. And again, probably provide more historical data than refresh, but again, it's all there. And I'll leave my contact information at the end if you have any questions about these resources or data that you can't find in our resources. I wanted to begin and end my discussion today by talking about policy. I think this webinar series is trying to provide information, resources, and ideas about how to advocate, how to navigate the legislative process and so forth. And I kind of wanted to begin by saying that my interest in the upcoming legislative session is primarily focused on workforce shortages and what we might do as a state to address those workforce shortages, and just point out the obvious, and that is remedies for what ails us in terms of health workforce compete with an endless number of other healthcare and public health challenges facing the state. I've listed all I could cram onto one slide and still keep it legible, but just wanted to point that out and ask you, as you think about advocacy or think about policy work, to know that you're competing not only for the attention of policymakers on policy bills, but also budget bills and so forth. What I've found to be productive and useful in thinking about how we move the needle on a workforce shortage related policy is to tie it to one or more of the items that I've listed here. That is to say, make it about addressing a problem, and I've again listed a number of them here, but be reminding lawmakers and policymakers that almost everything you see listed on this slide has a workforce component in some way or another. And so again, in thinking about shortages, thinking about workforce trends and data, that would be kind of my suggestion for those that will be engaged in the legislative process, rather. I want to begin kind of at an abstract level because I don't want to presume that you have an understanding or knowledge of workforce shortages. And this will not be all didactic like this in the next couple of slides, but wanted to let you know how I kind of think about the term shortages and what comprises that. In the absolute most simplest terms, a shortage is a discrepancy or a disparity between workforce demand on one level, and I mean demand from those who employ healthcare workers, and the available of well-trained individuals that are licensed in the state of Nevada or certified in the state of Nevada to provide a wide range of clinical cares. We can think about shortages inside and outside of healthcare and clinical care, but I'll be focusing obviously on the healthcare workforce. The good news is, and I will share some of that data with you here, is that we began to narrow that discrepancy, and that is to say, we have a number of professions, at least in the 25 years I've been looking at this, where we've absolutely made progress in the available supply. We still have a good deal of unfinished business, though, and that owes primarily to the fact that as a state, as we've seen the number of licensed health professionals increase, we've also been trying to keep pace with pretty rapid population growth over the last 20 years and some pretty steady population growth over the coming decade. So what's a good situation for us to be in? Pick your health profession, your behavioral health profession. It's not necessarily that we want to see a surplus, but at some point we want to hit that sweet spot where supply and demand are in some state or some level of equilibrium. It's almost kind of impossible in this state to achieve that, but we've absolutely done that in some professions, and I will point that out. So that in thinking about shortages, this particular figure highlights the conditions on that supply and demand line where we have a surplus or shortage, and then equilibrium being where they're in kind of at a similar level, if you will. Now, with all of that said, one of the things that I always like to point out with respect to shortages, shortage is, again, a discrepancy between the available supply of workers and the demand from employers for those workers and the services that they provide. I want to always point out, though, that what we see in Nevada is, in many cases, and it's certainly the case in primary care and behavioral health, which I will focus on today, that there's a level of clinical need above and beyond that demand. I always like to use examples from mental and behavioral health because, for example, if you looked at demand for behavioral health services, say 20 years ago, insurance plans didn't cover that, or they covered it poorly, or they pretended to cover it and still covered it poorly, and so forth. And what that resulted in is a level of demand as reflected in demand from employers that was substantially below the clinical care needs of our population. I think the same absolutely holds with respect to dental care. And again, a level of clinical need above and what individuals are able to pay out of pocket and or through insurance policies. If any of you have ever had a crown or a bridge through a dental procedure, you're typically at a minimum on the hook for half of that. And so a lot of that doesn't get addressed because people can't afford it, or their insurance coverage doesn't cover it. And so wanted to point that out. But again, if looking at strictly strict terms, we have made progress in addressing shortages, but I want this group and others to be mindful of the level of need. Now, before I begin, I just wanted to make a kind of a disclaimer, if you will, about some of the information that I'm going to present. It's really not a disclaimer so much as a limitation of the fact that a lot of what I'll be presenting and what we rely on to frame shortages in a given profession or a given industry is that we're quite reliant on licensure data and licensure counts from the 30 plus boards that license health professionals in the state of Nevada. A lot of what I'll present today is like total licensure counts. I'm not going to go through this entire diagram, but I think what we're ultimately interested in is the green boxes down below. So that if you look in nursing, for example, the section of the nursing workforce that is actually employed in a clinical care setting is a fraction of those that are totally employed in the state with a nursing credential, and they're an even smaller fraction of those with an active license to practice in Nevada. There's all sorts of folks that are licensed to practice in Nevada that either are not working, they're unemployed, or not looking for work, or they work out of state. Likewise, there's a number of individuals with an active license to practice in Nevada who are employed but not in a clinical care setting. So a little bit of a qualification on the use of licensure counts. And I think it's important because whether you're testifying in support or opposition to a bill that may be addressing shortage, be mindful of the type of data and workforce data in particular that they're bringing to bear on that situation. So I talked a little bit about supply and demand in the preceding slides, and want to give a super high-level overview of drivers of workforce demand. They're largely drivers of health services in general in the state of Nevada. And I'm going to pay particularly close attention to demographic and insurance-related drivers of demand for healthcare, which in turn are driving demand for behavioral health professions and others employed in healthcare. If we look at the past decade, our population grew in Nevada by 16%. that most of that was driven by population growth in Clark County, but I would point out that in northern Nevada, both urban and rural regions of northern Nevada, we've seen some pretty impressive, kind of above the national average growth in our state's population. It's not expected to grow quite as strongly in the coming decade, but still we're on par to add a little over 400,000 individuals, population growth rate of 12%. Similarly, when we look at our aging population, that is to say, pick your measure, but we look at the population age 65 and over, we're projected to see an increase of 24%. It's going to be substantial, and that's about 132,000 people across the state. Both, again, all things being equal, will drive additional demand for health services and thus the need for health professionals inside and outside of behavioral health. Fun little factoid that you'll find in the data book, which Valerie will be sharing or dropping into the chat, is that since the year 2020, the median age in Nevada has increased by 3 years from the age of 36 to 39. So the population is growing, the population is aging, and again, all things being equal, that will continue to drive up demand for a wide range of health professions in the state. I'd conclude by talking about, or at least mentioning, the fact that we've seen significant growth in insurance coverage in the state, which again will translate into additional demand for services and workers. If we look at the Medicaid program, anytime I see a Medicaid presentation, it's often stated that now 1 in 4 Nevadans are covered by this important public program for low-income individuals and the disabled. Right now, we have a little over 1 million individuals that are covered by Medicaid, and that is an increase over just the past decade of about 630,000 individuals. Likewise, in the Medicare program, we've seen over the past decade an increase of about 160,000 Medicare beneficiaries, or a growth rate of 36.8%. When we look at supply, just a couple of very high-level trends that I'd want to point out. And kind of the good news, bad news of the first bullet is we've seen a growth in the number of health professionals, but treading water. So if you think about a profession in which the number of licensed individuals is growing by 10% over a decade, past or present or future, but the population is growing at 15%. What we see is what I refer to as a treading water trend in the per capita growth rate. We see this a lot in psychiatry and clinical psychology, but better news in areas such as marriage and family therapists and some of the counseling professions where that licensure growth has exceeded population growth. Likewise, the point I'd want to make at a high level is we see shortages across a range of health professions in the state. And one of the things that's tough for behavioral health advocates is that you're competing with other sectors of the economy, other industries within the healthcare and services sector that is also facing shortages. Finally, I want to mention, already talked about an aging population and aging population as a driver for healthcare and healthcare services. The workforce is also aging. That workforce is a part of the community and society that we all live in, and that segment of the workforce is growing as well. Finally, I'll highlight some of the diversity and geographic maldistribution of healthcare providers. Currently in the state of Nevada, about 32% of the population is self-reporting as having Hispanic background or ancestry and so forth. I can guarantee you that there is no health profession that I'm aware of in which those providers can speak Spanish as a second language or culturally competent in the agreed upon sense of the term. Looks like we have a question. I'd love to take a question.
All right, John. So one of our attendees asked, will having MCOs in the rural or slash frontier region hurt the workforce or help? And so for background, for those who may not be aware, the state is currently, I believe the contract is still open for applications or it has closed and they're trying to make decisions. But there will soon be a managed care organization available for Medicaid recipients in rural and frontier Nevada. So those persons who would qualify would no longer be on that fee-for-service model that we have difficulty getting providers to take. So John, do you have any thoughts on whether having an MCO will help or hinder, or how will that affect workforce?
Well, I'm going to almost completely dodge that question because I would say it's too early to tell. What I think folks need to be mindful of and put pressure on those carriers. I think I've spoken to all of the folks applying to. They've reached out for information on workforce and projected workforce needs in the state. I take them at their word that they're earnest in making sure that the workforce and the available services covered in those plans are commensurate with what's expected of a carrier. But would just want to point out, and something I'll be keeping an eye on, is they're all bound by network adequacy requirements, whether you're a managed care carrier in the Medicare or the Medicaid market or the individual or small group market. Those all come with requirements, including behavioral health, about how many providers need to be available for the covered population. A hell of a lot trickier in rural areas in which, and I'll point this out in a moment, you could put all of the psychiatrists in rural Nevada in my Prius. That's how many few are practicing in rural areas of the state. So how is that going to be covered? Will telehealth be enough? Again, this will be a work in progress, but one of the things that state regulatory agencies can do and what advocates and folks interested in behavioral health can do is, again, keep those carriers faithful to the network adequacy requirements. Stay tuned on that. There will be more to come on that. I now want to get into a little bit of the trend data, and you'll notice in this presentation I emphasize primary care shortages and workforce trends almost as much as I do behavioral health, in part because I do a lot of work with rural providers and rural health professionals, and primary care is I think just a critical part of how we address behavioral health in rural areas, because oftentimes that rural health clinic or that community health center doc or PA or nurse practitioner is kind of on the front lines of providing behavioral health. The data presented in this slide is a snapshot statewide of primary care HPSAs or healthcare professional shortage areas. This data is pretty fresh, and again, you'll find this in the data book. Roughly 65% of the state resides in a primary care HPSA, and that problem is demonstrably worse in rural versus urban areas, but it's bad all over. And so when we think about addressing behavioral health needs, we kind of need to be mindful of shortages that exist in primary care, which I consider to be, again, the backbone of healthcare in rural areas. I wanted to share this information, kind of snuck this slide in at the last moment in preparation for this webinar, to give folks an idea of what goes into a HPSA score in primary care, and in a moment I'll do the same with mental. I won't get into the weeds on this, but I think it's important. This is a snapshot or kind of a zoom in on shortage areas up here in northern Nevada, and scores range from 0 to 25. Those HPSA scores are very important in affecting the designation of critical access hospitals, community health centers, provider loan repayment eligibility, provider bonuses from federal Medicare and Medicaid programs and the like. But this is kind of what goes into it, kind of at the heart of primary care HPSAs, and why I think this is useful is that it looks at population to physician ratios for physicians who are engaged in family or general practice, general internal medicine, obstetrics, gynecology, and pediatrics. And so you're not only getting a snapshot, for example, in this map of Northern Nevada, of where areas are short on providers, those scores are also dependent on the level of poverty in a given census tract, infant health, and then travel time to the nearest source of care. If those of you familiar with this map of Northern Nevada will note that there are not shortage areas on the west side of Reno, Collin Ranch, Somerset, and Arrow Creek areas, as well as Red Hawk up in the northeastern part of the county. The rest of those areas are at some level, again, of a primary care shortage in the eyes of the Health Resources and Services Administration at the federal level. Another set of data that I wanted to share with you, this is a little bit dated, but kind of thinks of this at the county level. The previous maps were kind of an agglomeration of census tracts with high or low scores. This is from the county health rankings, and I'm sharing this because we're looking forward to the next iteration or release with more current data in a month or two from the county health rankings and RIVMET's population. But a couple of things I want to highlight in primary care at the risk of stating the obvious, and that is rates of population to one primary care doc vary considerably across the state. As a general rule, those ratios are higher in rural versus urban areas. But even in 2 of the 3 urban counties, those rates are higher than the U.S. average. And if you look across the board and compare each county to that U.S. average, we only have a handful that are below. So again, acute, enduring primary care workforce shortages and challenges across the state. Now, shifting gears to mental health professional shortage areas and kind of greater concern to this audience. This is the latest data that we pulled together, trying to marry HPSA shortage areas, the way they're scored by the federal government, with current demographic data from the state demographer's office. We have a little over 91% of the state that resides in a mental health professional shortage area. 100% of rural and frontier areas. So the population covered by Valerie's Behavioral Health Policy Board resides in a mental HPSA, but it is an equal opportunity threat to both urban and rural populations, our shortage areas. Now, like the primary care scoring and designations, mental health HPSAs are determined in a slightly different way. And it's, again, population to providers, in this case, only psychiatrists, as well as the percent of an area, typically a census tract, that is below poverty. It also takes into account the additional mental health needs of older segments of our population, as well as youth and adolescent segments of our population. And to no great surprise, it takes into account prevalence rates for alcohol and substance abuse. Like primary care, it also takes into account travel time to the nearest sorts of care. This is a dated map that we're in the process of updating, but kind of, again, if you're familiar with Southern Nevada, you won't be surprised that shortage designations are lower or non-existent in the southern and southwestern part of the Las Vegas Valley. North Las Vegas, eastern Las Vegas, different story, where again, those provider shortages and deficits are a bit more acute. I wanted to kind of conclude this discussion of mental health like I did with primary care. This again is data from that County Health Rankings and Roadmaps project. What I like about this is this methodology includes not only psychiatrists, but also clinical psychologists, clinical social workers, a variety of counseling professions, and others that provide mental and behavioral health care. And even though those rates are higher in rural counties, again, than they are in urban counties, mercifully, we have individuals practicing in those rural and frontier counties that can provide a certain level of behavioral and mental health care to the residents of that population that I would argue have above average levels of need, clinical need for those particular services. They may not all be prescribing professions, but again, a critical part of the behavioral health workforce in rural areas. I'm going to conclude by talking again about those licensure counts with all the caveats that I mentioned earlier. And this really busy slide, I'm glad Valerie's able to share the slide deck with everyone, highlights the change. This is just change in number of licensees over the past decade. And across these professions, you can see both numerical and percentage growth. What I put in parentheses is a number that looks at per capita change over the same time period that adjusts that growth rate for each of the 7 professions listed here in terms of per capita change or population growth statewide. So I'll just pick one example, clinical psychology. We've only added 135 licensed individuals that are regulated by that board, a growth rate of 36% over the past decade, but the per capita change was roughly half of that. So not necessarily treading water, but again, numbers going up, but adjusting for population pulls that growth rate over the past decade down. We've had some phenomenal success stories in other areas. I would point out advanced practice nurses through the roof over the past 15 or 20 years, growing by almost 300%. I have to double check these percentages because they're kind of off the chart. But again, a good story that is a product of policy change. I'm happy to discuss as we go on. I'll conclude by a type of statistic that I think is very useful in communicating to state lawmakers and others about the nature or magnitude of shortages. I think we've all heard presentations where we're 47th in this or 48th in this or the bottom of the barrel, 50th rank on a given profession and so forth. I've used this number from employment data from both the state and the Federal Bureau of Labor Statistics to highlight to lawmakers about what would it take in a given profession to move us from a ranking of 40 or 45 or 50 to the middle of the pack or along the national average. And it's taking employment data, marrying it with data on national per capita averages. This is what we would need in just a handful of primary care and behavioral health professions. We need 171 more psychiatrists. Doesn't sound like a huge number, only until you think about the level of time and training that's required to produce one psychiatrist. We need almost 2,000 substance, behavioral, and mental health counselors as well, and so forth. I would also point out by what level of contrast and everything I've mentioned about primary care to this point, we have substantial deficits in most of the primary care areas, including advanced practice nurses, where we've made a good deal of progress over the past decade. I'm going to have a lot more information that's in a chart book that's going to come out in a couple of months on that for the 75 or 80 occupations that we track. I've tried to just share a little bit of a flavor of those shortages across the occupations I do have data on. We have a question, Valerie.
Yes. So I see Helen Bird asked, where are the licensed clinical social workers included? The 1,800 mental health counselors?
I'm sorry, could you repeat that?
So where in your past slide, the one that talked about the number of providers that are needed in those different categories. So the question is, where are licensed clinical social workers included? Is that in that 1,865?
No.
Or is that in
A
the spot?
great question, and I knew I would get that because I've left some of the information on this slide off of this. I don't have employment data that I have, or either I don't trust. I'm not trying to hide anything. That will come out too in the chart book, in that we're dependent on employment estimates provided by the State Department of Employment Training and Rehabilitation and/or the U.S. Bureau of Labor Statistics. And in that case, I didn't have employment estimates. And again, I'm going to spell that out in the chart book as something the state and state policymakers need to get their arms around, and that is we flat out still need better data on those and a good number of other occupations. Great question.
Absolutely. Thank you, John. So just a quick note for our attendees who may not be aware, licensed clinical social workers are one of the only provider types in the mental health arena that are allowed to work with persons who have co-occurring conditions on their co-occurring conditions. So otherwise, if a marriage and family therapist is available to them, but they do have substance use challenges in addition to mental health challenges, their MFT can only work on those mental health challenges. They cannot touch the substance use issues, in which case that person would really need two different providers in order to work through their treatment plan. So it's all of the different provider types are incredibly important, but the licensed clinical social workers kind of knock out a couple birds with one stone as far as connecting folks to care. Okay, and then the other one, Helen was just saying thank you. And then we had Lisa mention that unless that MFT is also duly licensed as a certified clinical alcohol counselor. Thank you so much. I appreciate that, Lisa.
Great questions, great comments. Appreciate that. I'm going to conclude as I began, and that's just a little bit of talk about policy. I'd like to talk more, but what is it? It is January 22nd. Bills are still coming. We're still waiting on bill language on some bills, but want to offer Packham's typology of policy options and have you be thinking about what I refer to as 3 buckets of policy measures at the state level that our legislature and our governor can pursue to address those shortages, increase the available supply of behavioral and other healthcare workers in the state of Nevada. The first bucket is what I call grow your own strategies. At the end of the day, there is absolutely no substitute for expanding the capacity of Nevada higher education healthcare programs that attract and make that education affordable to Nevada students and Nevada residents, and to support them once they've completed that training and education, because they're typically doing it with additional levels of debt. It also means building on or creating new programs where they don't exist. The point I'd like to make out about Nevada is that it follows along that Chinese proverb that the best time to plant a tree was 20 years ago. The second best time is today. So better late than never. We've been late to the game in so many areas. It was early 2000s when we built a first dental school. We didn't get around to building a public medical school in Southern Nevada. It's about a decade ago, really late to the game. I discovered recently that up here in Northern Nevada, the Orvis School of Nursing was created in 1956, and that made Nevada the last state in the union at that time to create a public nursing program. Again, those programs are responsible for producing the next generation of healthcare workers. And again, that needs to be, in my view, my humble opinion, at the top of the list of state policymakers. There's other measures in the following two buckets that I first refer to as measures that stretch the existing workforce. Good examples of that are telehealth applications, Project Echo type applications that wring out efficiencies and effectiveness with the existing workforce without necessarily producing one more health professional. Licensure scope of practice is another way. We increased that phenomenal rate of advanced practice nurses in 2013 when we allowed registered nurses with advanced practice training and certification to practice independently of physicians. Our rates went up through the roof as a result of that and continue to increase steadily as a result of that measure. The last category is almost a residual category of measures that we can take, typically borrowing or poaching workers from other states, if not other nations, but some more effective measures such as licensure reciprocity and interstate compacts that allow an individual who's licensed in good standing in another state to practice in Nevada, and vice versa as well. The next slide is just kind of highlighting those three buckets. Everything doesn't necessarily neatly fall into those three buckets, and I'll highlight that with a few examples in a moment. But as a general rule, as you move from left to right, up or bottom to down in this, going from the beg, steal, borrow, and barter strategies to grow your own, I would argue that the grow your own are going to have a more impact. The catch is they have a bigger price tag as a general rule. When you folks start tracking legislation that moves through the process or doesn't move through the process, I will make a not so bold prediction that most of those will fall into that stretch the existing workforce and beg, steal, and borrow bucket, which is not to say they're bad, but they're not ever going to have the same impact as grow your own measures that expand behavioral health care education, that expand medicine and nursing programs and the like. I've committed the Cardinal Senate PowerPoint presentations by putting way too much information on these slides, but what I have put in here are examples from Nevada and other states that I argue is measures the state can take. Again, lower impact, lower cost as you move left to right and bottom to top on this, but you get what you pay for. I would argue that most of the things highlighted in green are measures that will actually move the needle on provider shortages in this state. I've almost made it, and will conclude by pointing out that my office has a number of resources that will hopefully be useful in the work you do in your day-to-day jobs, as well as some of your advocacy work that you might be pursuing in the upcoming legislative session. That data book is one that 25 years later, we still print and put in a spiral bound edition to hand out to legislators. And I hope to have those copies available in 2 or 3 weeks, not only for their use, but for your use and those you work with in your respective corners of the state. And with that, Valerie, I think I will have a drink of tea and see if there are any questions.
Thank you so much, Dr. Packham. That was amazing. So I have a quick question while everyone's starting to form their own. And if you do have a question, you can either pop it into the Q&A box or raise your hand. I will give preference to raised hands and live questions. So my question is, so you mentioned on your slide the different types of strategies that we have that could bolster the number of providers. Also, earlier in your presentation, you mentioned that the number of providers we have is steadily climbing, although we're really just treading water with our changes in population. That being said, do we have any sort of evaluation data on what has been the most effective strategy thus far implemented in Nevada specifically to increase the number of behavioral health providers?
Oh, boy. The short answer is yes. And not only that, but we also have evidence, Valerie, of what other states are doing. My office is working with the Gwynn Center over the next year and a half to produce it's a document we're calling for the time being, moving the needle on health workforce shortages in the state of Nevada. And what that's going to provide is an inventory of not only what's worked in the state of Nevada, but also other U.S. states, so that we don't have to reinvent the wheel. We can build on successes in this particular state. The one, again, I'll go back to, it's kind of addressing that question, but indirectly, is the fabulous growth of advanced practice nurses in the state of Nevada, including the growth of advanced practice nurses that have specialty training in psychiatry and I think they're called psych NPs as a shorthand. And it's a really good example that was a product, again, of a couple of things that we know work across healthcare broadly and in behavioral health as well. And that is that change in licensure scope of practice, the ability to practice independently. Loan repayment, which allows those same nurse practitioners to receive dollars to offset the loans they've accumulated in their educational journey in exchange for working in a medically underserved area. And then finally, the growth of master's level training programs for nurses at both UNR and UNLV. In that case, again, both have small but mighty Psych NP components to that. They work, and again, they work because they are making they're attracting Nevada students. They're reaching out to high school and even middle school students to get them interested and start getting them jazzed about careers. But we're also sealing the deal with loan repayment and so forth. On this call, I want to give a shout out to my colleagues in Sarah Hunt's Be Here Nevada project. That's one more element that will help move the needle in behavioral health, because we're going to deploy, among other great things that they're doing, AHEC-like activities in the area of behavioral health. It's a lot trickier talking to a prospective high school or middle school student about untreatable chronic depression, or how to deal with suicidal patients or substance abuse disorders, than it is to go into a high school and talk about medicine or nursing or a career in dentistry. And so that's again, one more arrow in our quiver to address workforce shortages. And I'm saying that those grow your own strategies move the needle, but all of these are complementary. Licensure compacts, loan repayment, workforce pipeline development, and behavioral healthcare are, we need all hands on deck.
Awesome, thank you. So any other questions for Dr. Packham? All right, hearing none.
Valerie, before we sign off, I think my contact information is in the slide deck. If anybody on this call or webinar needs additional data or clarification of data, please don't hesitate to reach out. I believe that the reason the Nevada Health Workforce Research Center exists is to make sure that policymakers and the public are armed with the best data that we have available that speaks to not just shortages, but to the health of the state.
Awesome, thank you. And I did put that the data book into the chat. It's also, I will be posting it momentarily on nvbh.org. The slides from today are also in the chat and on nvbh.org. One more note, please, please, please take a look at the data book because it breaks down these different professions by county, even Washoe and Clark. So while we didn't have time today to take a deep dive into the different professions in each county, that information is in the book. So thank you so much. All right, without any further ado, thank you everyone for participating, and please go ahead and check out the other webinars we have coming forward. Thank you.